Hi, everybody, and welcome to our TCOYD live event. So, yes, we actually are live. So, whatever platform you're watching in, as this goes along, feel free to enter questions into the box, and we'll get to them at the end. Because we do a lot of online content, these days, but we don't do a ton of live events. So we want to give the people what they want, get in front of them, and actually be here. This is all happening live right now.
And this is a special live event, and you can explain why it's so special.
Yeah. So, we have some housekeeping stuff, but just kind of broad strokes, what we're going to be getting into today. What is a virtual forum? What does that mean? Well, Steve and I just attended this major diabetes conference, and we hold every year this event, which is a panel of 5 diabetes experts talking about what they thought was the coolest thing that happened in diabetes at this conference. But it's very, high level kind of doctor talk. It can be a lot. So what we wanted to do is take little snippets of it, and then Steve and I are going to give it, kind of our commentary on what this actually means, how it actually might apply to you guys living at home with diabetes.
Yeah, and just to add that you saw the advertisement. It's called the Forum. We've called it the Diabetes Forum. We've been doing it for 18 years, and it is the event at the American Diabetes Association, and we do it in association with our very close partners, Diatribe. Mm-hmm. And where Kelly Close founded the organization and is on the stage with me asking these panelists questions. So it's been a pleasure to work with Diatribe. Both organizations really work hard to educate people with diabetes about the latest and greatest in diabetes.
Yeah. Now, before we get kind of more into it, the one event we wanted to let people know about is that we are doing our ONE conference, ONE, which is actually happening in 2 weeks in person. It's our one event that we do a year that's actually in person, a weekend here in San Diego, August 16th to the 18th. So again, it's coming up, but if you feel like, hey, I'm in West Virginia and I could use a trip to San Diego, please come out. We have a ton of excellent speakers. The vast majority have type 1 themselves. We have a band playing. We have fun runs in the morning. There's pool time. There's hanging out at the bar with your buds. It's a fantastic event if you've never been.
Yeah, and in addition to the fun and listening to a Beatles band put on by Eric, our videographer, you'll learn a ton of information. And as Jeremy said, nothing against healthcare professionals that don't have type 1, but we have primarily all of our speakers have type 1. So there's this extra camaraderie, empathy, know how you feel kind of attitude.
Mm-hmm. And if you can't make it this year, trying to come next year. It really is awesome. I'm looking forward to it. So back to the forum. So where this happened is that there's this American Diabetes Association conference that happens every year in June, and it rotates cities. It's not always in the same place. So this year it happened to be in Orlando, and I'm sorry if you live in Orlando, but it was kind of...
In June?
Yeah, it was lame. It was hot, it was sweaty, like whatever. And the conference goes on for about 4 or 5 days, and we held this event that you're gonna see on the last day. So the conference had taken place, every day is jam-packed with information, and we held this event, and we had several hundreds of people in this room kind of hearing, again, these experts take on what they thought was the coolest thing about it.
Mostly drinking and listening. Because a 4-day meeting, so many lectures and presentations. I'd just say one quick fun thing. There is a thing in Orlando called the Ice Bar. And when it's humid and hot, we went there, and it was a great place to cool down.
Well, Steve always likes to say, and this is true, he took his shirt off in the Ice Bar. He did it like 20 years ago, and then he redid it this time, which was...
14 years ago. Yeah. He always exaggerates.
So, and again, this is an event, and the way it works is that Steve is one of the moderators, and Kelly Close from Diatribe is one of the other moderators who's asking questions to the panelists. And we have to give a quick shout out and thanks to the sponsors that helped put this event on, and Eric's going to put kind of those up. And the last thing I'll say is that if you do want to donate for this event, saying thank you for this education, there's a special link that you can go to that will get up on the screen, and all the proceeds will go to TCOYD and Diatribe to continue, putting on this education. There's a QR code there for you. All right. So again, nuts and bolts, how this is going to work. Well, we're going to introduce the topic, and then we're going to show the clip of actually the responses that happened at the event. So,
yeah. And Eric has the timer.
Yeah.
needs to turn it on one of these days. And then we're going to go on for the next 30 minutes. But I think you'll like the way we condense the most important issues for you. And we'll add commentary to each one.
Yeah. So broadly speaking, and we're kind of jumping around in the order that it actually happened in real time. But this first topic that we're going to be talking about is the use of non-insulin medications in people with type 1 diabetes. So Steve always gives me a hard time. I get on my soapbox.
You have to do it.
About how, I'm jealous of you folks with type 2s that you have access to medicines like Ozempic, Mounjaro, and Farxiga, and all these great medicines that help lose weight and help protect your heart and your kidneys. But type 1s generally can't get them. They're not approved. So this was our first topic here at the forum. And this clip is going to be of a physician named Ralph DeFronzo.
We should probably introduce a one-liner on him, too.
Yeah. So tell us, who's Ralph?
Well, Ralph DeFronzo is a giant in the field of diabetes. He is not only an endocrinologist, but a nephrologist. And he has pretty been on the forefront of all the major studies. He's got a lot of history behind him. And let's hear what he has to say.
That we haven't done more for people with type 1 diabetes. In particular, I'll talk about the SGLT2 and I'll make a comment about GLP-1. People with type 1 diabetes develop kidney disease. It's not any different from type 2. They develop atherosclerotic cardiovascular disease. And it's a shame that SGLT2 inhibitors are not approved for people with type 1 diabetes.
Well, let me just say first, for all of you non-rocket scientists out there, Ralph is using a lot of jargon, which is why we're doing the forum this way. What he's saying is SGLT2 inhibitors like Farxiga and Jardiance, and drugs like Ozempic and Mounjaro, Trulicity, they have benefits way beyond glucose control. They protect the heart and the kidney. And what he's saying is there's no reason why people with type 1 could not enjoy the benefits of those protections as well.
Mm-hmm. And, we just a minute ago recorded a podcast with the CEO of formerly JDRF, now Breakthrough T1D, Aaron Kowalski. And this is a big push for them too in the research area, that this is becoming unethical almost to say, if you have type 1 diabetes, you can't take these medications that are hugely beneficial in all these different areas. So we need more research. We need to push these companies to get these medications approved. And if you're thinking to yourself, I don't know who Ralph DeFronzo is, I don't really care.
Well, that's not right.
No, but I mean, they might say, I don't, these names don't mean anything to me. But why we're saying that is that people in the room are listening, and it carries some weight of this, he's right. We need to get on this to help get these meds approved for type 1.
And the other thing that happened at this meeting, Ralph DeFronzo is primarily a type 2 guy, his whole career, insulin resistance and all this stuff. And I think there wasn't a single panelist that did not say, these drugs really should be available for people with type 1.
I was actually kind of blown away because you might have noticed the handsome guy on the right was me.
The look on your face was like a deer in the headlight.
That's normally my go-to thing. That's when he started talking about it, I was out of stuff to say.
I mean, Richard Pratley, they all said it.
Yeah, it's cool to be into type 1 these days.
Yeah.
So the next topic is kind of along these lines. It's actually very much along these lines. So you're saying, well, why aren't these oral pills like Farxiga and Jardiance, why aren't they approved in type 1 diabetes? And the real reason is that they cause an increased risk of diabetic ketoacidosis. Your ketone levels can become elevated, and that's a problem for people with type 1. Thankfully, your CGM's going off.
There it is.
Gosh. Thankfully, there's companies that are working on, in addition to continuous glucose meters, CGMs, continuous ketone meters, CKMs. And that might be a way to kind of unlock these medications for folks like with type 1. So we have a very informed panelist talking about this specific issue. Let's roll that.
And I have some comments after.
Oh, thanks. Utilize these medications, and I think continuous ketone monitors are a way to potentially do that. So I think that is Steve and I, maybe we disagree. I think that's a niche, but I think it's an important niche. The other people that get really excited about this are just the non-diabetics and, the people that are just want to be on a ketone diets and things like that. What is this? It's caused this type 1 backlash of their appropriating our technology, which I think is actually kind of fun. Like, like this is for us, it's not for you, because we don't get that many things. So just go do your freaking marathons without your, continuous ketone meters. But anyways, I think it will be, a welcome addition, especially, you add it to the backbone of a continuous glucose monitor, which we're already using. And if it can also display ketone information, why not? And if we can use it with these other medications, et cetera. So I really welcome the addition.
Yeah,
well said.
That was well said, especially the word frickin'.
Freaking.
We should give kudos to Abbott, the makers of the Libre, to advance this technology. There's a lot of buzz about it at the meetings. Not quite sure when it's going to come out, whether it's going to be, with the glucose, whether the data is going to show all the time. Those are other questions that Chantel Matuller brought up, one of our other panelists, because she's from Belgium, and I remember her comment quite clearly. I'm going to get a little clip when I do that debate. She goes, I've never discussed a topic where there were so many questions about it. But I think my feeling is this: euglycemic decay or decay from anybody that's on a pump or the infusion line pulls out happens way too often. And if people can be notified early, they can do risk mitigation at home before you end up in the emergency room or in the hospital. So I think that's important. And I should say one more thing. You can't just go to the store and buy ketone strips, which you can buy right now. They don't measure the right type of ketones. This is what we call, ready for this, beta hydroxybutyrate. It's a certain type of ketone that really identifies someone at risk for ketoacidosis. And we don't have that now. We do have.
Well, the strips, the blood strips measure that.
Right, the blood strips. But then you got to have a glucose meter with you.
Right.
You got to have it with you. You don't have frequent values. Each strip is about $1. So I do think it's a wanted addition to our whole technology.
Yeah. And just real quick, the way that the companies are developing these is that 99% of the time you don't need to know what your ketones are. You're probably fine. So these devices will display your glucose like you're used to, but then only show you, your ketones have become problematic in an area that you need to kind of, intervene on. So this isn't a whole new other gadget with lots of flashing stuff that's going to be driving you nuts.
Well, it's going to need to come with lots of education, not only for us folks that use it, but also for healthcare professionals. Mm-hmm. But it is something that is new, and you guys now know about it.
Yeah.
CKM.
And again, last thing I'll say on this topic is that the NIH, Breakthrough T1D, they have a call for research applications to use these devices in people with type 1 to show that we can use these medications safely to finally get them approved. That's what this is all about. Yeah. We want type 1s to have access to these medications. So,
and ketoacidosis can be lethal if untreated.
So, all right, so that was a lot of type 1 stuff, other medications. We're going to shift gears into obesity, a little bit of type 2 diabetes, because keep in mind, this is the American Diabetes Association meeting. All these things are being discussed, and it's really difficult to distill it down into the 5 top things because there's so much going on. So this next clip is our good friend Jenny Luna, who's also an endocrinologist that's been on many of our events here. She lives here in town, who has a niche, a specialty in obesity or weight management. And just kind of getting her overall take on obesity. And I'm just going to leave it at that, and we'll see her clip, and then we'll talk about it a little bit more.
Yeah, listen carefully. She speaks words of wisdom.
Is a multifactorial disease because it's influenced by different factors. For instance, genetics can predispose individuals to have obesity. Environmental factors, such as not having access to healthy foods or a safe place to exercise. Psychological factors, stress, emotional eating, and biological factors, because the body is defending the higher weight. So our patients that have obesity are struggling with all these different factors. And when we approach the care of obesity, we want to take a comprehensive approach where we have lifestyle modification, psychological support, pharmacotherapy, and for some patients, bariatric surgery. But again, getting into the personalization of medicine, whichever intervention or treatment plan is chosen, we always have to make sure to take into account our patient's unique needs and their other health conditions, in addition to involving the patient in the decision-making.
Well, Dr. Luna is so well spoken. I could listen to that clip a few times because she covered a lot of important things. Now, the whole panel had their comments and opinions about weight loss pharmacotherapy. On one hand, they all were extremely impressed with the weight loss seen with Mounjaro, Ozempic, Trulicity, but yet there was a lot of folks saying the problem is people can't get it, they can't afford it, and access is too tough. And so they all agreed on that. And then there was one of the panelists, I believe it was Ralph, that said, I don't care what you do, diet fails in terms of leading to significant weight loss. It's tough. Anybody that's viewing us right now who have been on several diets, just know you've been on every diet. It's so tough to gain, it's so tough to lose, easy to gain. So the data on these drugs are extremely impressive to the level of replacing bariatric surgery. But yet on the other hand, there's a lot of folks around the world, and this meeting had 11,000 diabetes specialists from around the world. Some countries don't even have the basics. So it was a big issue, if you remember that discussion.
I think, from Jenny's comments, it's just helpful for our viewers to see how far obesity science has come. 20 years ago or even less, it was, well, you eat too much, pretty much, and you need to just eat less, and
exercise more, eat less.
You're morally weak, that you don't have the willpower. And we've learned that is just absolutely not true. She's talking about the genetics of the disease, hormone imbalances, access to food, all these things that really kind of come together. And yes, diet and exercise is extremely difficult, and in general, it does not work. Doesn't mean don't do it.
Right.
Do it in combination, hopefully with one of these, medications or these new therapies. And like you said, the GLP-1 drugs, Ozempic, Mounjaro, have been game changers. That for people that can get them and can stay on them, avoid side effects, people lose substantial amounts of weight. I'm sure you've all, run into a friend you haven't seen in 6 months or a couple years, and it's like, where'd they go? People melt on these drugs. So,
and let me just add something that will go into our next topic. But you said get them and stay on them. And that's a big part of our discussion because these are lifelong therapies. They protect your heart, your kidneys, you improve your diabetes, they lead to weight loss. And we know a lot of people do not continue them for a bunch of reasons. Can't find it at the pharmacies, can't afford it, insurance changes, and there are issues with that.
Yeah. So going into this next topic, which is related, is that as this data is coming out, that people lose 20% or more of their body mass, or their body weight, people have started doing research and saying, well, where exactly is that weight coming from? Is it all just fat, or is there some muscle mass that's being lost? And a lot of the data is showing, yes, you lose some muscle, and that I kind of think that makes people concerned. Just hearing that, I don't want to lose muscle, I want to lose just fat. So we asked this next panelist, whose name is Richard Pratley, who actually works in Orlando, well-known endocrinologist, has a lot of research in this area, what his opinion was on that topic.
It's more opinion than data. People...
I agree.
People look at weight loss and the body composition studies with these drugs, and they see that generally 25% or so of the weight loss is lean body mass loss. And they go, oh, this can't be good. You're going to get weak, you're going to get sarcopenic, and you're going to get frail. In my clinical experience, when people lose weight, this does not happen. They get more functional, and the loss in lean body mass, I view as being physiologic. You don't need as much muscle mass if you're carrying around 50 pounds less. If I put a 50-pound vest on you and made you wear that for a year, you would gain muscle mass. That's not pathologic, that's physiologic.
So I think that's a good perspective. That, I think, again, people hear losing muscle and it just immediately thinks bad. Like, you're going to lose weight from kind of everywhere. Doesn't mean that you're going to become weak, et cetera. You can continue to train. And I think the point he's trying to make is that generally when people lose weight, they do become more active. They can do things they haven't been done before. Maybe not finally, but doing the exercise they've always wanted to becomes more achievable, for example.
Yeah, I mean, what people have been talking about, at least I've been saying the same thing until I went to the forum, is that when you lose weight on these drugs, yeah, you lose some muscle, you lose some fat, but when you go off the drug and you gain weight back, it's all fat. So, that doesn't sound good. When you don't want to go on the yo-yo with these drugs because you'll lose muscle and fat, but gain back fat only. So it's one of these, that's why I said it's a lifelong therapy.
Yeah.
But what he said was quite interesting.
Yeah.
Can you hand me my 50-pound vest? I want to get some muscle
For
mass.
real. Some other just general concepts with these drugs is that generally the more weight you have to lose, the more weight you lose. So people say, what if I only need to lose 5-10 pounds? Well, first of all, screw you. We all
This is
need
not to go to your son's wedding, okay?
So it's not like you're just going to become super, super skinny. That's how it works. The other thing is that the weight loss tends to plateau or like around 6 months or so. So it's not like you just keep going and going and going and going until you're nothing. It tends to kind of level off.
Yeah, and you should all know that one of the discussions that we talked about that's not on one of these tapes is that the American Diabetes Association treatment algorithm, they give doctors direction on what drugs to use first and second. But if you have a patient that's extremely overweight or has heart disease or kidney disease, that one of these GLP-1 drugs, perhaps an SGLT2 if it's a kidney issue, should be used first, even before metformin, which has been the first drug of choice for centuries. So that's how important they are. Even the regulators that are very, they're very conservative in their suggestions to doctors, and it really is a game changer.
Yeah.
It's changed the way we treat type 2.
I think as we leave this topic, it's important for people to realize all the ongoing research is still in these drugs and weight loss, et cetera. The first GLP-1 drug was approved in 2005, I think, by Pettus. So they've been around for about 20 years, and we keep learning more about them. Why are people losing weight? What kind of effects is that having everywhere else in the body? Generally, and this isn't true of other drugs, the more data comes out, the more positive it is.
Yeah.
When it just started, it was all about blood sugars. And it's like, oh yeah, now people lose weight and it's good for their kidneys and their heart and maybe helps with addiction and brain function. I mean, it's wild.
Yeah.
So anyways.
Well, can I say one more thing? You know what? In terms of, in the topic of these drugs doing more and more things, in the beginning, the SGLT2 inhibitors like Farxiga, Jardiance, they were really known to help prevent the progression of diabetic kidney disease and reduce congestive heart failure. So now the GLP-1s were primarily heart attack and stroke. The recent study, the FLOW study, we don't have time to show the clip, but Ozempic or semaglutide has been shown to reduce the progression of diabetic kidney disease and also congestive heart failure. And it turns out that SGLT2s do way more than reducing congestive heart failure. They reduce heart attacks and strokes now. So both
drugs good for your heart and kidneys.
Why didn't you just say that? We
Yeah,
just saved
for
10
crying
minutes.
out loud.
I wanted to impress upon our viewers. Seriously, it's two impressive classes of drugs.
All right, so we're going to shift back to type 1 diabetes. Another broad topic is, we've talked a lot about it, this at TCOYD, is that we have now teplizumab, otherwise called Tzield is the trade name for it, which is the first drug ever approved to delay the onset of type 1 diabetes. In people that don't have it yet, they have a family history maybe, we can screen them to show that they're at risk for getting type 1. This drug's been shown to delay that onset by about 3 years. So this has been big in the field of how do we screen people? Who do we find that might need this drug? How do we find them? Once we find them, how do we get them this drug? It's been a major, just kind of heavy lift in terms of implementing this into our clinical care in our world. So we asked again, a very well-spoken young doctor to comment.
The handsomest guy on the panel. Let's play the clip, Eric.
Really interesting. There's a lot to talk about here, that this is a drug that's been, efficacious in terms of delaying the onset of type 1 diabetes. But I have to say that, at UCSD, at UC San Diego, a major academic center, we just did our first infusion a month ago, which I'm personally embarrassed, by. That I've been, involved in this research and screening and all these things. I actually went to the P&T committee to get this drug, approved, et cetera. And so I think it just really speaks to the gap, the huge gap that exists between, having a new therapy in this space, in this instance, to delay the onset of type 1 diabetes, and where we are in terms of finding these people, of screening, of identifying people at risk. And not only that, even if we identify them, the painstaking efforts it's taken for us again at UCSD and across the country to set up the infusion center, to develop the protocols of when to check labs and who's going to take call for these patients that endocrinologists are just not used to. Doing this in an infusion center, all these things has been a lot of work. And that every institution that I've spoken to has kind of had to do this on their own also. UCSD has come up with their own thing. We tried to do a University of California call, but UCLA was so different from us that they couldn't enact the same protocols. Even our own children's hospital that's right down the street is on a different system, so we couldn't enact that. So it's taken a lot of work. But the good news is that I think this is really laying the foundation for what's to come. We've done so many educational efforts now on just reminding people that type 1 diabetes is an autoimmune disease. And before now, we didn't have a reason really to talk about that. We talk about continuous glucose monitors, insulin pumps, et cetera, which is so important. But hey, let's talk about a T cell and what this is actually doing. And here we have a therapy that can actually modify that. Things that have been going on in other autoimmune diseases for decades, we're finally talking about in type 1 diabetes.
No, we're back.
Yeah, we're back. You know what? Just to give you a little more background, this study done with this drug called TZIELD was done in people who had what we call stage 2. They had no symptoms at all, but they had these markers, these autoantibody markers, Islet autoantibodies. It's just a blood test. And it showed you can delay the onset of true type 1 diabetes for 2 to 3 years. Now, what Jeremy was referring to in that clip was that you have to be in an infusion center at the current time. It's a 30-minute infusion for 14 days in a row. And so just setting up the protocols was very, very difficult. And so it's the first disease-modifying drug to prevent the development of type 1 diabetes. So it's huge in our field. And Jeremy knows a lot more about this topic than I do. What else do you want to add to this?
So I think the big question now is how to screen people. So as Steve mentioned, it is a relatively simple blood test. And if you have 2 or more of these autoantibodies in your blood, we usually test 4 or 5 of them, you are at high risk of getting type 1. And that's kind of the easy part. But then how do we recommend this screening? And a big debate going on right now is, should we implement universal screening? Meaning that at a certain age, 4 years old, 5 years old, whatever it is, should we screen everybody in the United States to see if they're at risk? Should we start making this into our protocols for kids like we screen for other things, cystic fibrosis, all these things that the pediatricians are very used to? And it's not there yet. So what we're relying on is just educating people that you can get screened. You can ask your doctor to order blood tests. You can go to a website called TrialNet. It's a research organization that actually send you kits at home where you can do a finger stick on yourself, your kids, or loved ones. Send that back and get results. But then it's, how do we interpret that information? Who does it come back to? And what do you do once you get it? So all these kind of things are being worked out. But the good news, like I said, is we got a drug now. And all these conversations are happening.
If you're watching and you have type 1, it's not for you. You have to be the person that says to your first and second degree relatives,
get tested.
You should get tested. And it turns out that 80% of the people that come down with type 1 diabetes like Jeremy and myself, do not have a family history. So it's even tougher to do screening in an individual who's at risk but has no family history. You say, what are you talking about? But once it gets approved, or other drugs get approved for the newly diagnosed type 1s, then there'll be floodgates open because, as you say, what happens when someone gets type 1 diabetes or someone's kid? They start making phone calls. What could I do? But right now, it's in the stage before that, stage 2. Full-blown type 1 is stage 3. So it's really, this area is at its infancy. And I don't think we could handle the number of people who would want to get infused if it was indicated for new onset type 1. But as you mentioned, getting things set up right now is so important. And it's important to know, and you can even start making preparations, because if you have 2 or more of these autoantibodies, your chances are 100% over time.
Yeah. So look into getting screened. We've done multiple podcasts on this topic.
Yes.
Other, TCOYD live events, et cetera. So maybe the final kind of area we're going to talk about, again, another type 1 thing. But a lot of research going on in, okay, we both have type 1 diabetes. We've already gotten it. All of our beta cells are dead.
Was that good English?
RIP.
We already gotten it.
Beta cells. We already gotten it. I got in a bad case. But can we replace beta cells? Can we give them back? What's going on in what we call islet cell replacement? Islet cells are the ones that make insulin. So how do we give them back to people? Can we use stem cells, et cetera? So this is one of the panelists named Chantel who's talking about that topic.
Replacement. I remember Doug Milton a couple of years ago. I can make buckets full of islets. Well, there's a few companies who can make buckets full of islets now. And they can manipulate them, and they can make them less appealing for the immune system. And everything we learn in disease-modifying therapies for delay or arrest of beta cell destruction will also be of interest for these islet replacement therapies. So the most exciting times, Kelly, and I always thought I would see a prevention and a cure for type 1, and I do believe I will see.
Well, I think we'll wrap it up with that, meaning that an important area that we actually can take these cells, infuse them into people. That means do an IV. They take up in people's livers and they start producing insulin. However, the downside is that you need to take chronic immunosuppressive therapy like you would if you got a kidney transplant. And those drugs have side effects. They can cause infections, potentially long-term risk of cancer, et cetera. So the research that's going on in this area is how do we give these cells back to people and not require immunosuppression? There's ways of, can we encapsulate them in a device of some kind to protect them and implant them into people? Or can we edit them genetically? So, Aaron Kowalski again was saying the Harry Potter cloak of invisibility, where you make these cells kind of invisible to the immune system so they can make insulin, but you don't need the immunosuppressive therapy. And that can happen, and that's when it would blow the roof off of this whole situation, that everybody could get it.
Yep.
Right now, like when people say, well, I want islets, why can't I, should I get them? Absolutely not. It's really kind of for people that have long-standing type 1, lots of complications, et cetera.
Yeah, one thing that happened at the ADA meeting is they showed data from individuals in the current study that's being developed by Vertex, big company, very devoted towards coming up with a cell-based cure. And these folks, well, first let me say they only took half the amount of immunosuppressants that someone would have to take if they had a kidney transplant or a heart transplant. So the less, the better. And not as bad as most people think. But saying that, these folks got off of insulin.
Yeah.
They were normal. And it was their choice to volunteer for the study, take low-dose immunosuppressants, I'll just call it low-dose immunosuppressants for now, and to have a successful islet cell transplantation. The other thing I should say is...
Well, I was just going to say, I don't care how many islets you got, I don't think we would ever make you normal.
Very funny. But I would say that things have changed since we've been able to synthesize these islet cells, not getting them from human placental,
And
you
that's,
know.
that's what she was talking with, buckets of islets, that they can actually
Yeah.
make these in the lab now and not require organ donors, which is where they've come from historically.
That
Yeah.
opened the door for a lot of things. So I think you said it nicely, the different ways we're trying to get these islet cells, you know, and have them survive with or without immunosuppressants.
So that's it for kind of our clips. So if you haven't entered a question now or yet, you can still do it now and we'll go through some of those. But our goal from showing you these clips is to let you know that, you know, at TCOYD, we're committed to giving you kind of the cutting edge information, research, et cetera, and you just saw it. This was information that was being given to physicians, healthcare providers, you know, researchers, et cetera, and you heard it from their mouths and then kind of our interpretation of it. So you know that you're getting kind of the latest up-to-date, you know, info on these topics.
Yep.
Yeah.
I enjoy going through it again.
Yeah, and the one person we didn't hear from at the event was you, but that's because you were the one asking the questions, and that's why we got you here too. But Steve does a fantastic job of really laboring over what are the coolest questions, you know, working with each panelist of what they want to talk about, et cetera. So kudos to you, Steve.
Thank you.
Yeah. All right, so some questions. We're going to do these kind of, you know, we're going to give them the appropriate time, but try to do them a little bit quickly so we get through as many as possible. So, one, do you need to increase tirzepatide or Mounjaro from the lowest dosage if you're already getting results? Your appetite's down, you're eating less, et cetera. So for any of these drugs, these GLP-1s like Ozempic and Mounjaro are probably the two most common, and Trulicity. There's no right dose. They all have multiple doses that you can go up to, but you should just target, you know, what you're really looking to get. And I encourage people before these medications they start these to really think about that and even potentially write it down. I'm taking this medication because I want to lose 10 pounds and I want my A1C to come down or whatever. And if you hit that target, you don't need to just keep ramping up the dose for no reason.
Totally agree.
Yeah.
Nothing to add. There's no, the perfect dose is the dose that gets you to your goal without causing nausea, which is the main side effect.
Yeah. All right, are pharmaceutical companies doing studies in GLP-1s and SGLT2s and type 1? So I think we covered this. So there are some companies working specifically for indications for type 1s and GLP-1s. And then for the SGLT2, like the oral medications, I really think it's going to be the continuous ketone meters that will help get across the finish line. Now, that being said, if you have type 1 diabetes and you're overweight or obese, you can get these GLP-1 medications approved sometimes just for weight loss, or your provider can be a little bit selective with how you enter your diagnosis. So for example, there's a diagnosis called diabetes type 1.5, which means you have type 1 diabetes with features of type 2 diabetes. You might be overweight or insulin resistant. And I've had a lot of luck of that actually getting covered with insurance companies. So there are little tricks you can get them approved. Or if you already have kidney disease or heart issues, you can get them, you know, prescribed specifically for those issues. So they're not just globally approved for type 1, but if you fit into some of these little buckets, sometimes you can get it. Does that make sense?
Yeah, it does make sense. There's a company called Lexicon who has a SGLT2/1 inhibitor, and they got turned down. Jeremy and I were at the FDA hearing because they were worried about this DKA issue. Now, since then, it has been totally discovered that they have tremendous effects on the kidney and the heart. So I kind of might disagree with you a little bit. I think with those indications, they may get it approved with or without the continuous ketone monitoring.
That's right.
And they are going for the indication for type 1s who have chronic kidney disease. So we're going to have some videos on that in the near future. But I do think the momentum is building.
Yeah.
And people are thinking about this very strongly.
Can you be diagnosed with type 2 and then re-diagnosed with type 1? Yes. We talk about this a lot. It's nuanced depending on what your specific question is. But frequently, somebody with type 1, especially as an adult, might be misdiagnosed as type 2. So you come in, maybe you're 40 years old, your blood sugar's a little high, they just label you as type 2, but you don't respond to medications, you need insulin. So you just need to get the diagnosis right. That's kind of a larger topic.
Well, how do they do it?
You can check these autoantibodies, you can check something called a C-peptide, but basically you just have to let your provider know, hey, I was diagnosed as type 2, I think I don't really fit that profile for these reasons.
Yeah.
Can you check my labs for type 1?
The one I'll tell you to ask for, if you're going to ask for one thing, is the GAD, G-A-D, autoantibodies. That's the one that you should get, and that can help determine if you're a type 1 or a type 2.
We didn't cover this really, but which insulin pump is the best? And there is no answer to that question because it really depends. So again, we had Aaron Kowalski here an hour ago. Between the three of us, Aaron, myself, and Steve, run 3 different systems. And we all have our reasons of why we chose that particular one. So, getting on one of these hybrid closed loop systems, Tandem, Omnipod, Medtronic, the Islet, and doing a little bit of research, talking to a provider about why you might steer me towards one or the other. Quick example, Steve likes the Omnipod because it doesn't have, tubing, and et cetera. There's lots of, we've done a lot on this topic at TCOYD, so
Yeah.
check out our video vault.
Put it this way, I suggest that you look into each of these systems, and we assume you're thinking of a hybrid closed loop system where the pump communicates with the CGM. That's the only way to go. Look up into each one. Look at the pros and cons. Talk to people. Talk to the representative. Pick the one that fits your lifestyle the best. And I can tell you they all work well.
Some of these we've kind of addressed. So how do we get into studies for Tzield? So again, this is not for somebody who already has type 1 diabetes currently. You don't need to be in a study if you're looking to prevent it because it's actually approved. So you could go on Sanofi's website, I suppose, or Google teplizumab. It depends on what you're looking to exactly get out of it. Again, if you want to be screened for the autoantibodies or screen your family member, the TrialNet website, Trial, T-R-I-A-L net, N-E-T,
Yeah.
has a lot of information about how to get screened.
The Barbara Davis Center, Ask, A-S-K, and the JDRF, but now I should say Breakthrough T1D. And the screening can actually be free. If you're someone with type 1 and you have kids, you should really order the little card and just prick their toe at night. They won't even wake up, and turn their blood in. And then that way you will be knowledgeable if they are at risk. And if they are, you can prepare and go and sort of, do the proper test at the hospital. And if they don't, you can take a sigh of relief and get them tested at some other time.
Yeah. Couple questions about Afrezza, specific things here. Afrezza is an inhaled insulin, works very well for people with type 1. We don't prescribe it enough. Providers aren't familiar with it. It's very quick acting. You inhale it, it works almost immediately and gets out of your system very quickly. You can use it with these pumps. And again, we've done whole talks on this on our video vault on our website. So go to that to check it out because it's not something I can answer in 15 seconds.
Yeah, well, if we're talking about the forum and the ADA, there was a big study released there that they took a bunch of type 1s who gave themselves insulin the normal way with injections or pumps, and the other group took either basal insulin or a pump with Afrezza as their only mealtime insulin, and it showed that it was equivalent with less hypoglycemia. And that's what's nice thing about Afrezza. It gets out of your system quickly. You don't have that prolonged action, which can cause delayed hypoglycemia. So it was an important study looking at the benefits of Afrezza, and it clearly was positive.
My endo's not knowledgeable on Afrezza. How do I get them to basically look into this? So I would just go in and say, hey, look, I've done my education, watched some of our videos on TCOYD. I would like you to prescribe this for me so I can try it. And if you get a lot of resistance, change providers.
Yeah.
Unless they have a really solid reason of this isn't for you. It's just a lot of providers don't know about it, and because they're not comfortable, they won't prescribe it. They'll just tell you it's just vaguely it's not good or something like that.
Yeah, I this is a serious suggestion. Go to C's Candy, buy a really nice box, and say, listen, I would love to try Afrezza. I'm giving you this because you might help me with a prior authorization, and I appreciate your time. I know it's limited, and you can bring a bouquet of flowers depending on who your provider is. Nothing hurts by giving them gifts.
This
Eric,
last one.
I'm serious. Eric's laughing back there.
There's a general question about stem cells and the different sources. And right now, the stem cells that we're using for islet cell replacement are what we call these. They originally, a long time ago, came from embryos, but for many years and even decades now, they've gotten them to the state where they can just replicate them in the lab. So when people, like, there's all kinds of concepts that people have about stem cells, that they're all coming from babies and things like that. It's just not true.
Politically sensitive too.
So these stem cells, there's enough to be made in perpetuity for everybody with diabetes without ever going back to an embryo. And I think that's really important for people to know. Finally, is there somewhere to see progress reports on type 1 diabetes advancements? Well, TCOYD is a great place to come for, diabetes education. Again, if you haven't gone to it, tcoyd.org, we have a watch tab that has something called the video vault. You can click on type 1 or type 2. There's categories if you're interested in exercise, nutrition, whatever it might be. We also have a podcast that has clearly labeled topics on, breakthroughs. Our actually number one listened to podcast is on the science of type 1 diabetes, where we talk about a lot of this. And then the Breakthrough T1D, formerly JDRF, another great website to go to check out kind of what's going on.
Yeah, and the diatribe.org, they have fantastic articles and very up to date.
Yes.
And I'd say extremely extensive. And so between the three organizations, and there are others too, ours, we do a lot of video productions. Diatribe is reading, and JDRF is a little, JDRF, Breakthrough T1D.
They just changed their name like a month ago, by the way.
It's going to take me like a year to figure this out. But it's a great change because, as you all know, juvenile diabetes type 1, the old name for type 1, can occur in anybody at any age. So they are.
I was telling Aaron now that JDRF might be available, I'm going to grab that. The Jeremy Diabetes Research Fund.org. So check me out. It's a great source of information. So hopefully you guys found this useful. Again, trying to think of new creative ways to bring you kind of the latest and greatest. It's fun. It takes a lot of work for us to go hold this event, chop it up, reproduce it, think about it. But I think it comes out well.
Yeah.
Yeah.
Thank you all for coming on today.
And there's the QR code in case you want to donate. Thanks to Eric, who's behind the scenes. And one last thanks to Diatribe, too, for putting this on with us.
Thank you, Diatribe. And